practice. So that may be what you were referring to earlier, White Marsh Psychiatric Associate.
Did it have a couple of iterations before then? I remember, I can't remember how long ago was it, but 10 years ago or 15 years ago,
it was Bay Region.
That's it. Bay Region. Yeah.
That's it.
So now it's White Marsh Psychiatric Associates.
Yes. It's right over by the mall, Campbell Boulevard.
And is that an insurance-based practice or out of pocket or
insurance?
Okay,
Yeah.
that's good to know. I mean, it's nice to know my colleagues here about where to refer when either. Yeah, that's great. And Terry, are you out? You're in Bel Air?
Yeah, Bel Air, Harford County, insurance based.
Very nice. That's probably an underserved area. I don't know, is that an underserved area out there in terms? I imagine White Marsh has, I don't know what the concentration of child psychiatrists. I guess Howard County and Baltimore County has enough, or not. Well, where I'm in Lutherville, a lot of places, but are there a lot of child psychiatrists out there in Bel Air or in White Marsh?
Not in Harford County. There's, I think, one other, but that she may actually be in Baltimore County. I'm not sure where the line is. And then I think University of Maryland Hospital hired someone to work with the hospital system in Harford County. But our catchment area is, Maryland's such a small state. Delaware, Pennsylvania, and Maryland. And it was interesting. I'm sure I'd like to get your all's input as well. With COVID, and I started doing telehealth, my geographic catchment, so to speak, has enlarged.
Yeah.
Is that what has happened with my colleagues as well?
Yeah, for me, I've noticed that, especially the young adults going off to college, whereas in the past I would have had to transfer them. Now, they're in Salisbury or, different areas of the state, I can continue. So that's a change.
Yeah,
yes.
I found that as well. And people who would come up from Annapolis or, far away from Lutherville, I can do that a little bit easier, which is nice for them. Kind of getting used to telehealth. It's kind of nice, but I miss seeing people in person. They're starting to come back in.
Yes.
But I would say it's still about 70–80% of them are still telehealth.
Yeah, most of mine are telehealth. I've been going in once a month to see Medicare patients. But starting in a couple of weeks, I'll be going in full time, just to make sure that all my new patients, if it's ADHD, that I can write a stimulant prescription and then go back to telehealth.
That's a new twist.
So I think we're going to start at 6:40 just to give more people time to join. We had I think a total of about 21 people. So hoping some more will join in a little bit.
Okay.
Now the silence is deafening.
Nice.
There we go.
There we go.
Is that included in the Zoom subscription that you have music that you can click on? Nice,
Roxanna's really good at managing all this stuff. I don't know how she does it actually.
great.
Well, we hit the 6:40.
Well, I feel to be respectful for those who are here, I think we should probably go ahead and get started. Does that sound okay with everyone?
Sounds good to me.
Okay, I apologize. I hope you can't hear the interference in the background. I got my neighbors are mowing. It's getting loud here. I hope you can't hear it. Anyway, I'm Mary Cutler. I've been a part of the MRCCAP Council for the past, I think 3 years now. And there was interest in starting, a group, more geared towards the private practice psychiatrists in the area. I have a history in private practice myself. I did that for 6 years, actually, when I was right out of training. But now I'm working for the Children's Guild, doing school-based mental health care in their OMHC. But Natty was interested in having, starting up a group to get people more involved and to really, I think bring people into MRCCAP and not just the folks who are at the academic institutions. So I think this was a really great opportunity. We're very lucky to have some really wonderful private practice child psychiatrists with us today. Stuart Varon, Terry Pritt, and Natalie Iser-Newton. So I would like each of them to sort of introduce themselves, tell us a little bit about why they went into private practice and anything else that they can. If you would like, you're welcome to put questions in the chat. If I guess if you have a burning question that you want to ask in real time, maybe raising your hand on the, with the reaction screen, that could be helpful. And since it's a smaller group, we could probably manage that. So Dr. Varon, would you mind getting us started?
Sure. Okay. Well, thank you so much for inviting me. This is really a pleasure, and it's nice to meet some of my solo practitioner or private practitioners. So I went through the questions and put down some answers to kind of give some structure. So I'm in full-time private practice since 2005. I've been in half-time. I started about 2001, and it wasn't something that that I started out saying I want to be in private practice. Actually, I was trained as a community psychiatrist, and I came to Baltimore for that. But then around the end of the late 90s, early 2000, there were a lot of funding changes in how community psychiatry was funded. And so jobs kind of disappeared or got reduced. And so I went into private practice and first half-time and then full-time. And I've really enjoyed it. I like the business end of things. I'm a solo practitioner. I pay for all my benefits. So I happen to like those kinds of things. But, in terms of people considering private practice, if you do the solo practice and your primary wage earner in the family, there's a lot of things that you have to search out on your own: disability, life insurance, pension, et cetera, et cetera. And so you kind of have to like that. There's a question about marketing. I don't advertise. My practice is fee for service outside of insurances. So the way that it came out for me is, first of all, when I was at Sinai Hospital before coming to private practice, and they closed child psychiatry right around the time of the Columbine. That's a whole other discussion. But they really closed it. And so they said, look, you have your patients. We don't have a place to put them. You can bring them where you want. And so I brought that. One of the questions was, how long does it take to fill your book? So I had a number of patients coming with me that I cultivated over at Sinai Hospital. And so that was kind of a nidus for creating my practice. But one of the things that helped me in kind of growing is I kind of like to talk. So when there were Sinai or a community or organization wanted somebody to speak on child psychiatry things or ask the doctor or medications, I would accept, and I enjoyed it. And then what would happen is they would advertise the talk, and then your name is out there. And plus then people would come to these things that want to see who's, who's talking and maybe be a provider. So that was something that helped with my practice. And I still like doing it. It's just a way of giving back to the community. The other thing, which is very good medicine, is calling this primary care providers when I would see one of their kids, or the referring psychologist or social worker. And people like to have phone calls. And I happen, again, enjoy that. It's good continuity of care. And so that was another way of establishing relationships. And so the pediatricians, who even more now than 20 years ago, are really strapped for time and energy when they get to know who you are and get to, find out somebody made a phone call. They're really good about referring. And but again, it's not something that I plan to do, but it just was creating those relationships. And when a pediatrician or a psychologist who somebody's going to says, I want you to go to these guys, parents will go for it. And because they trust their pediatrician. And so again, as an out-of-network provider, it's very expensive. So I really value those kind of referrals. In terms, there's a question about slow periods. It's not steady, but over time, as the practice builds, people will then begin referring, and so there's less and less slow times. And actually, I kind of enjoy the slow times because there's less phone calls. But to that nature, it's strictly about a person when you have the practice, kind of budgeting yourself, what your cash flow is, what are your monthly responsibilities. And so from a personal level, in terms of budgeting, and also from a practice point of view, knowing what my bottom line is to make it every month is real helpful in kind of figuring out how much I'm going to take on, how much I may not take on. But over time, those slow periods kind of get less and less over time. But to help the shortfall in finance, if you have some breaks in the schedule, taking a line of credit from your bank is a good idea, because you can plug financial holes by borrowing it short term and then paying it back when you have more busy times. In terms of how do I adjust the fee, how did I come up with fee schedule? I kind of took what Hopkins was charging privately for their evals and their half hour, and then I lowered it by a little factor. And then that's kind of what I came up with. I don't know if it's still the case, but I remember there was a kind of anti-monopoly kind of like clause somewhere in a law. You couldn't talk with other people about their fees because it's like price setting. So I really don't ask people what their fees are. But, if somebody asks me, I'm happy to tell them. Anyway, that's how the fee structure went. Now, every year I increase it about 3 to 5%, which translates out to about $5 to $10 a half an hour. But I do it. Some of the clinicians might do it every few years, but then patients get a large bump up. So I found that every year I go up, whatever time it is. And until recently, cost of living would be about 2 to 3% a year anyway. So, I would keep ahead of it by 0.5%, a full percent. So probably every 4 to 5 years, I bump it up $10 a half an hour. And then every year after that, it's $5. And so I'm happy with that. And that seems to work. In terms of what I charge for, there are half-hour visits, or I do a 2-hour eval, and then a half hours. Well, try to stay in a half hour. It doesn't really work too well. Sometimes it's 35, 40 minutes, but I don't like charging for the extra time unless somebody is really, really going above and beyond. Like, then I'll charge them for the extra time. But usually people just, if they don't like it, they leave. But most of the time people are very patient, and I try my best, but they always get the time they come in for. But in addition to that, I'll charge for letters. Not like, my son has ADHD, but, like for IEPs, lawyers, if it's sometimes a forms, and you kind of have to balance it because people don't like to be nickel and dimed. And so that's why I folded into the half-hour fee, knowing there's going to be a lot of non-billable time. But when it comes to letters, extensive letters, I'll charge, for the time spent. I'm beginning to think about charging for prior auths because there's so many of them now. But I always charge for an appeal. And again, for a small amount of a fee. That's not going to cover the whole fee. And people are actually pretty okay. If I said, look, I didn't get it the first go round, would you like me to appeal? And they're like, sure, and I charge, I think, $35 for that. So that's kind of how I do that. But again, it's a balance, and you can't charge for everything. That's not the field we went into, but you do have to get paid for what we do. The other thing is I will charge for time spent with people that my patients pay to talk to me. So lawyers, patient advocates. I don't charge for talking to doctors and things in between. Like if somebody's following the plan that they're supposed to come in every month, every 2 months, whatever it is, as long as they're not playing games, I won't charge them for visit phone calls. Just a part of like being a doctor. In terms of, I don't do extra income, but I'm solo practice, and I like the solo practice because it allows me to focus. Solo practice. I practice in one location as opposed to having several locations. For me personally, that would be too distracting. I know one of my colleagues, Mike Levelarte, has several offices. I don't know how he does it, but he does it, and that he's figured out his model. But for me, I like to be in one place, and I get to focus. Anyway, I don't want to take too much of your time, so I thought I'd maybe end it here. I have a few other things, but I'll let other people talk and then pick up some questions later.
Great, thank you so much, Dr. Beer. That was a really wonderful introduction. Dr. Iser-Newton, would you care to go next?
Sure. Hello, and thank you again for having me. So just a little bit about myself really quickly. So I did my adult residency at GW in DC, and then I did my child psych fellowship at Hopkins. And right out of training, I started working at Kaiser Permanente in White Marsh. And I was there for 3 years, and I very quickly realized that the lifestyle, the work-life balance was not what I was looking for. I became pregnant with my first child while I was there, and then I went down to half-time at Kaiser and realized that I was still working just as much, just less time. I was getting paid for less time, but had just as many patients. So that was my motivation to look into private practice. And actually, Mary was very helpful to me during that time. So I enjoy doing things like this because oftentimes we have to talk to our colleagues that are doing it, you know, if we're thinking about what it might be like and if it's right for us. So what I ended up, you know, interviewing at lots of different private practice groups. So I am currently a child psychiatrist at White Marsh Psychiatric Associates, and it's right across by White Marsh Mall. And it's a smaller practice, about 13 people. Right now, it's 3 MDs, 3 psychologists, PsyD and PhD, 3 social workers, 3 NPs. And so that model has worked very well for me. So I've never worked more than 2 days a week. So it's always been pretty much part-time for me. When I started, it was probably working so little hours. It was probably about 3 to 6 months until I became full. But simultaneously, I was doing locums. So while I was getting to build up my practice, I worked in a community mental health center as a medical director for 6 months. And then I also did some school psychiatry. So I did them simultaneously, which was really nice about private practice, that it was flexible enough that I could take one day out of the week and build up my practice while doing other work to have income. And so in terms of marketing, being at a group practice, I really didn't have to do any marketing because they just put something out in the lobby to let them know that I was can you hear me? Okay. And then I also, you know, the other practitioners that were there would tell their patients and refer, you know, in-house. So it was very easy and quick to build up patients for my practice. So when I think about what I wish I knew going into private practice was, I think, the aspect of vacation time. So you're essentially paying for vacation twice, right? So you're paying for your wonderful trip, but then you're also not able to see patients during that time. So you're not getting paid. So that's something that's important to consider. And just as I've been in private practice longer, I now plan better and anticipate that time off. So then I might add an extra day here or there prior to the vacation to kind of make up for that time where I won't have that income. So there's definitely a workaround, but I didn't realize that at the time when I first went into private practice. And so other things, I'm looking at the questions that we were given to address. Other things that have come up. So thinking about the fee schedule. So at this private practice, we do take insurance, all major insurances. I do not take Medicaid or Medicare, but other than that, everything else. And so we do have a practice manager that negotiates the fees with the insurance companies. Certainly, it's not going to be the most money, you know, especially compared to fee for service. But I find that sometimes it's a different population of patients that maybe can't, you know, go the fee for service route or don't want to do the getting reimbursed after the fact. But those fees are reimbursed by the practice manager. So at my practice, I take home about 75% of what I make. And so for me, I'm okay with that because what that includes, you know, what I'm paying to the practice includes the office staff. Usually there's about three to four people that are fielding phone calls, scheduling appointments, you know, if I need things to be faxed, basically anything that I need to get done administrative wise, they're there for that. As well as there's one woman that's worked there for like 25 years that I've grown to trust. And for a lot of the docs, will even like refill non-controlled substance prescriptions. So if I'm, you know, at my kid's soccer game and a patient needs a refill of their fluoxetine, you know, that's something that she's able to do on our behalf. So there's a lot of, as an extender, as a for additional support, it helps with work-life balance because, you know, there's that support staff there. The 75% that I keep and the 25% for the practice also includes the billing staff. So I don't have to worry about any kind of billing paperwork. They submit things if patients aren't paying to collections. You know, they consult with me. Do I want to send this to collections or not? So it's nice not to have that headache of, you know, keeping up with things, as well as it includes the office space, computer, furniture, supplies, use of the EMR. So I have 3 young kids. And so when I'm finished seeing patients, I pretty much want to be finished and not have to deal with some of that other administrative. So that's definitely a bonus for me to be in a group practice. Also, after hours, if calls come in, it's very rare. There are 2 people typically that are on call. I've never signed up to do call, but there's a nurse practitioner and an MD that will take call if my patients ever, you know, they'll call the main line and it'll direct them if they have an urgent situation. It's very rare, but it's also nice that I'm not getting calls, you know, in the middle of the night or having to worry about any of that. Let's see. How do I manage difficult cases? So I really do enjoy the camaraderie of interacting with colleagues. And so that is one aspect of private practice to think about, that it doesn't have to be. I mean, it's great to be solo, and it does sound like, you know, we were talking about how you go out into the community and you're interacting. But I do also find that having like peer supervision is really helpful. So whether you're a solo in private practice or in a group practice, the peer supervision, whether it be on Zoom or telephone calls, that kind of thing has been really helpful. So, you know, there is a weekly peer supervision that we have that's helpful in the before COVID, when I was in the office more. You know, it was great to just be able to, at the end of the day, go next door to my colleague that's, you know, almost in retirement, to be able to just bounce things off and talk about cases, or in the kitchen, you know, you're there and you're able to talk about cases. So that's another thing that I really liked about being in a group practice, is being able to kind of talk about some of those difficult cases and have that support. Let's see, before I wrap up, I don't want to take too much more time. Another question that came up was, where do I see the future of private practice psychiatry? I actually think that it's going to grow, especially with more and more NPs being hired in some of these bigger companies. I foresee that more MDs are going to be going into private practice because these big businesses are looking for a way, you know, a cheaper way to conduct patient care. So I imagine that we will see more people going into private practice. But overall, I really do like the flexibility of it. It helps with my like I said, I have 3 young kids and just always things come up. I like that I have that flexibility to say, okay, I need to take this day off, leave early at this time, let's change my schedule. So that level of flexibility is exactly what I need for this time in my life. And I do like that as I go through different stages, I can change my private practice as to what my needs and my family's needs are at that time. Okay, I'll stop there.
That was great. Thank you so much, Nally.
Sure.
Dr. Pritt.
Oh, hi. So I'm Terry Britt. Thanks for inviting me. I came to Maryland in 1998 and started at Shepherd Pratt, and that's where I met Dr. Varon. He was at Sinai. So what was helpful for me, being a complete stranger to Baltimore and Maryland, was networking, talking with psychiatrists, therapists, first at Shepherd Pratt, and then when I was through Catholic Charities, talking with people in the community. And that has continued to be very beneficial. And that's how I get my referrals. I don't do any marketing. It's all word of mouth, either by patient, they will tell me that they referred a family member or a friend or school personnel, or particularly local therapists who I've worked with through the years, and I've done this a long time. They've known me, and so they will refer to me. I'm insurance based, and so a lot of times it's insurance companies that will refer their clients to me, where John Doe has called Aetna or whomever, and say, is there a psychiatrist, child psychiatrist, or even adult psychiatrist in the Harford County, Cecil County area? So networking is just good, I think, to reach out somehow to the community, to schools, to colleagues, psychiatric as well as therapy colleagues, to let them know you're there and that you will talk to them anytime. And then if there's a difficult situation, you're going to give them a call as well. As far as how long it took me to build up the practice, well, this is a very small group practice. I'm the only medical person still in the practice. The others have retired, and it's difficult to recruit where we are. Particularly, it's because we take insurance, and so it's just important to talk to your colleagues and to have a good support staff. The support staff, as I think you mentioned, Natalie, are essential. They help with the prior authorizations. They help with if I'm traveling somewhere and someone needs Zoloft or Prozac or whatever, they call right away. And then if there's something that can't be, they call in, then I can take care of it when I reach my destination a couple hours later, or an emergency phone call, they will let me know. It's also important to make your connections with not only colleagues, but with your malpractice carrier, to have someone who you can call and say, I had this really tough situation. I'm not sure legally, and professionally, ethically, where do I go from here? Or if you're subpoenaed particularly in a custody case, or I've been subpoenaed a few times, my patients actually suing somebody else. Very uncomfortable situation, but you can you're paying for this insurance, and so you utilize that legal department of your insurance carrier to help guide you, to give you the best information. I also encourage that whether you're just coming out training, or like me, who was in academia for a while and then went into private practice, to always be connected with professional organization. The Child Academy is great. That's where I get my continuing education, through the Child Academy. The Maryland Psychiatric Association, APA, also great. The local Maryland Psychiatric Society, oftentimes in their newsletters will tell you about some new regulation coming through the state or through the feds. Make sure that you sign up with any new things from the DEA, the new requirement that the DEA is going to have, as far as having 8 hours of training in opiate, I'll call it treatment, we have to have to get our DEA license. So, again, I guess under the umbrella networking, make sure that get connected with your local organizations. So I'll turn it over to you now.
Thank you so much, Dr. Pritt. I think that is so important, that idea of networking, because it can be a little bit isolating in private practice at times. So I think you're so right about that. One of the questions that's come up in the chat, I guess this would be for Dr. Varon, to comment on after hours and vacation coverage when you're in solo practice. How do you handle that?
Right. So yeah. So right. So not having the group, which it's really lovely having all of those supports. So a couple of things. I cover myself. I don't carry a beeper. I go through voicemail. So that way I have some control over my time and when I return phone calls and that. So when I'm on vacation, I've connected, talking about networking, a few private practitioners where we cover for each other. I try to spread it out, so not any one person gets or request. So that's what I do. But I don't give out my, well, sometimes people get the cell phone, then they call, but I really try to keep those kind of things to a minimum so that I have some control of my time. One of the things I miss being a solo practice is that you don't have the mothership kind of kind of covering for you or of those kinds of things. But I like the solo practice. It gives me there's a lot of time commitment, never really goes away when you're even on vacation or otherwise. When I'm on vacation, I try to take a break. But the other thing that I really like about it is this group of patients that I'm kind of taking care of, that I really have an investment with. And so it's it has positives, but the negatives are that not being connected to the momaship and other practitioners, which would be very nice. So we network with other people in similar situations and we help each other out. It's kind of how that works.
Actually, Dr. Pritt, I think that's probably a good question for you too, since you're the only, I guess, medical practitioner in your practice, right? How do you handle coverage?
Well, what we do is, once I became the only person around, I spoke to my insurance carrier, and they apparently, if you legally say after whatever time, or on weekends or a holiday, if the office is closed, no one is there to let me know, call 911 or go mobile crisis. We have a mobile crisis team in Harford County that actually will go to a person's house, so they don't have to go to the emergency room. I always give enough medication to last into the next appointment, and that's sort of when someone asks for a prescription, I kind of go ding, 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 they've missed an appointment, and sure enough, they have. And now the local ERs know me, and so if it's a horrible situation, they call me like on a weekend or holiday. And in all my years, I've only had one person get mad at me for not being around on Christmas Day. and but she didn't like what Mobile Crisis did. And she said, "You know me all these years." I said, "Yes, I do know you all these years." So again, I think that networking, knowing what the legal ramifications and ethical ramifications are, and that can help you. Now, if I'm going on vacation, I'm going to take a long 4th of July, I have someone cover for me, someone in the community cover for me. And as Dr. Bear mentioned, that can either be someone, we could be trade off, or sometimes you pay that individual to cover for you. But those are things, and so when you go into practice, you have to go in with your eyes wide open. It's difficult the first year or two, because you're making a name for yourself, hopefully a good name. You're balancing the financial aspect. You're learning all sort of the tricks of the trade, and I'm still learning some of the tricks of the trade. And you're kind of building up that nest egg so that when you do take time off, you won't get paid. So you got to have enough time set aside to kind of cover the bills until you to come in. Now, when you take insurance, if you take time off, the insurance reimbursements still keep coming in from previously, because turnaround is about 4 to 6 weeks. So some money is coming in. It's about half of what I would normally make in a 2-week period. If I take 2 weeks off, I'll make about 50% on one pay period, and then the next pay period will be about 75, 80%, and then I'm back up. So about a month I'll be off, but you saved enough to make it. So I think it's important to understand that you don't have that safety net, as Dr. Varon mentioned, of the mothership, of your benefits, of a salary.
That's great. Now, I'm wondering actually, this question would be for all of you. Maybe Dr. Eiser-Newton, you could start out. But do you operate, from a legal standpoint as an LLC, or are you an employee of your practice, or how is that legally structured?
So for me, I do have an LLC, and because I'm part of the group practice, I get a K1, which I'm considered a limited partner. So that's so it's just because I have an S Corp LLC, with regards to taxes and all of that, and then I just get the K1. So it's not a 1099, but it's a K1.
All right, I'll jump in. And
Yeah, go ahead.
So I'm structured as an LLC, solo practitioner. And for those that, an LLC, you have to have a lawyer or paralegal write up the articles. They call it articles of business, I think it is. And then it's a $300 charge every year through the state of Maryland. Incidentally, just as independent business person, I always like to tell people, you want to make sure also you put aside for your pension, because and so there are different vehicles that you can do that. One of the nice parts as a solo practitioner, the limits of putting in for a retirement plan are greater than if you were to be in a company. I think I forget what the limits are, but there's something called a SEP IRA. I think that's called a single employee, solo employee. There are different mechanisms to save for retirement. So I have what's called a SEP IRA. And I think you can put the max in is like $66,000 a year. And I think it's based on what your income is. You pay 20% of that. So anyway, I always say to people, even my contractors that are independent, that come to the office, to the house to do something, you have your SEP IRA, because, you work so hard as an independent, clinician, that, it's easy to forget about. Say, well, down the road, I'll put in money for my IRA. But really, I always suggest that, especially from a tax, you're going to be in a higher tax bracket. The IRA or the SEP IRA is going to be a tax deductible or tax deferred issue. And so it can impact positively on your taxes, and then you save for the future. And then as you get older, you have a nest egg there, and maybe you can work less. But I always tell people that don't forget to fund your SEP IRA. And whenever I have it set up that I know how much I'm taking out of my practice. Is a certain draw every month I pay myself, certain amount, and included in that, my account says, here's how much you can take out for your SEP IRA. And every month I put that in for that expense, so that I don't get behind in that. So, and then, really for the type of structure, really to speak to your accountant, which makes sense, an LLC. For any of us are PCs, professional corporations, there's a whole, tax piece to which is best how to structure. Oh, the other thing is, by the way, so if you get a 1099, or I don't know how you do it, other people do it, but for me, the accountant says, okay, here's what your estimated taxes are. So every quarter I have to pay taxes. And so again, as part of my budgeting, I take out from my draw, take out from my pension, and I also take out what the estimated taxes are. And I put them in an account every month, because then that way it doesn't come to bite you at the end of the quarter, like, oh my God, I got to pay this. So, and there's also, if you underestimate by a certain amount, there's a penalty. Like if you come the end of the year and you owe more, a certain percentage above what you estimate, is a penalty. So you speak with your accountant and they give you an estimation. And then, every quarter, and if you put it away, every quarter you have the money available and you're not scrambling for when it's time to pay. And then I always put a little extra aside for taxes, because inevitably, I guess it's a good thing, I have to pay more than I expected, because each year when I go up in cost, it's more income. So just a cash management strategy there. Become friends with your bank. By the way, if I could just add, I'm sorry, go ahead.
No, I was just going to add on to that, Stuart. You're exactly right. Plan ahead financially. Plan, for all your taxes, your retirement, your malpractice, disability insurance. Particularly if you're young. I've reached the age now where my disability said that we don't want you anymore. So, so I don't worry about that. But you save that, and then the rest is your spending money that will pay your mortgage and household expenses and your fun things. Have a good accountant. Who will help you through. And I work with a bank, and they call me a private client, not because I'm a billionaire, but they do like doctors, okay, because they know that we will make a decent income, and we're needed in the community, and they will work with you, not only with your practice and lines of credit, but with a mortgage, refinancing, like my house mortgage, for example. They worked with me several years ago and did that. So that's going to be important too.
One thing I would suggest in terms of working with a bank, or things that you purchase, right? So all the things that, that the other doctors have talked about, is keep an eye on the fees for the things that you purchase. I have a storage unit. I'm still a paper guy with some electronic medical record. I still like my paper. I don't get ransomware, so I can operate every day. So, but anyway, I have charts, and I have my storage locker. So it's a public storage. It started out at $49.99 a month. It's up to $192 a month. But I go on their website, and the same unit is $66 a month. It's like, what the heck? Because, so I'm going to do something to lower that by getting another storage unit in the same building, and it'll come down, because the companies count on you not. I bet you lot of people don't read their statements. They don't know what they're paying for. So they can increase the costs, and you're kind of sitting there. It's like the paper guy, it's like, I get the paper. Oh, it went up for whatever. Call them, that's a little expensive. Oh, good day for you. We're going to lower it back to the previous price. Or, you cancel. Oh, no, you don't want to cancel. We'll lower it again. So it shouldn't be this way, but it is. And so I would advise that know what you're paying and know what you're paying for. And periodically, you're a good customer, you can renegotiate. The merchant processing, if you take credit cards, keep a mind on what you're being charged for. Now, I used to go through M&T Bank, and all of a sudden I read those statements every 6 months, and I'm being charged for something. What the heck is this for? And without going into the whole detail, right? It was an erroneous charge. It took me 10 phone calls to figure it out. But in the end, it was $700 extra that they mischarged me, that if I didn't read my statement. Now, I tried to call and nobody could figure it out. So I read that if you go on ceoemails.com, you can get this email of the CEO. And I read that through a personal finance magazine. And I did. And they tell you how to write the letter and what not to say. And the next day, the head of merchant servicing from M&T Bank says, oh, yes, sorry, our fault. But the point is, and then I got my $700 back. And then I went to Square, and it's much easier and it's much less. But even then, after a year, I call them up, say, what can you do for me the rate? Because here's how much I'm sending you guys every month. They renegotiate. So the point is, know what you're paying for, read your statements, and periodically relook at and see if you can get a better deal. And these things turn into real dollars and cents. So that's my little plug.
I agree with
Along
you.
those lines, it's also helpful, like when you have an LLC, to keep track of all of the business expenses that can be written off. So, malpractice, insurance, all the different, there's so many things that we pay for that can be written off. So also important to work with your accountant on that as well.
Yeah, that's true. That's a big difference, because when I was in private practice, there was a lot of these things that I could write off that, simply can't do now that I'm an employee. So it's a completely different structure. And there's a lot of those advantages. I had an individual 401k, Stuart, which was, I guess, sort of analogous to that, but I was able to put so much money into that. I actually couldn't afford to put in that much money that I was allowed to put in. It was a lot more than I am currently able to put in. So yeah, so a lot of advantages there. Would you all mind commenting on some of the pitfalls or problems that you have, or things that are maybe a thorn in your side in private practice?
And once you do that, we do have a question in the chat after.
Well, I can start. Even though I'm in a small group practice, being the only medical practitioner, you do feel somewhat isolated. So that can be a downside. Dealing with insurance, well, there can be a little bit of negotiation with the insurance company. They're very happy to refer to the nurse practitioner down the street, who they charge less. So and they will, that's sort of the biggest competition in Hartford and Cecil County right now. And so that's a kind of a worrisome trend that I've seen over the past several years. And then the cases that I do get, which are quite a few, are more complicated, which I don't mind, but you kind of have to undo some things to straighten those situations out.
Yeah, I would say that's a similar concern that I have. It's difficult with negotiating like when I talk to the practice manager about negotiating the rates, it's it's not easy to deal with the insurance companies. So that's an unfortunate aspect of it.
I'm sorry. Go ahead,
And prior authorizations are just becoming more and more and more. And heaven forbid, if you have an adult who has ADHD, it's every year you have to get a prior authorization for the same medication and same dose.
I think that's, you know, the downsides. I mentioned some potential downsides. But the prior auths has become more onerous in terms of time and stupidity of things, which I'm sure you all can appreciate that. So that and nasty patients. I don't like nasty, but I don't have a thick skin for nasty patients. Thankfully, most are not.
Yeah.
But the 1% or 0.5% take, you know, they're not satisfied with this or that. Thankfully, it doesn't happen that often. But I kind of have a rule. If anybody's, I have an administrative assistant. I've been very thankful. I've had her for she was with me at Sinai, and then she came over with me, and actually she lives in Israel now. And everything is voicemail, and she's really good at that. But anybody yells at my secretary or whatever, you don't stay in my practice, because you know you gotta take care of your support staff. And I pay her more than probably person could earn, but that's my lifeblood, you know, and she fits everything in and so forth. The thing that I find also tough is sometimes the time spent, which I love working with my patients, but sometimes it gets a little bit much, not because that they're asking for anything. Some people are really sick. But I think it's just a lot of time and a lot of mental energy. Again, I don't mind working extra, which I do a lot, but I thank my wife for being very patient. And so when I'm working extra, I'm not working for a bean counter, which is nice. It's a win-win. The patient likes it, I like it, and there's money coming in. The downside is figuring out how much is enough and when to say, I'm sorry, I can't. And then, you know, the hardest part, because I love what I do, the hardest part is so many people in need. What I do is a public health disaster because, you know, it's out of network. And to try to work with people. I don't do a sliding scale because I don't know what one person might. I remember one time a lady took an extra cleaning job to pay the bill. Actually, it was at Sinai, and she was whatever her copay was. I can't tell the difference between that person and the one who goes to Aruba but says I can't pay. So I don't get into that. And then I refer to people who take insurance because then they have an insurance for that. But the hardest part sometimes is seeing how much unmet need there is and how much angst that people go through with the people that we treat. And that's probably the hardest part, but I don't think that would be mitigated by any work situation. But when you're solo, you carry a lot, except I do split therapy. Like I always like working with therapists because you split it and also you have different ways and then you have somebody to communicate with and brainstorm with.
Another pitfall in this day and age is the lack of child therapist in the area. And so what I try to do in my brief time is to give little pearls to the parents. And they're searching oftentimes for months to find a child therapist that has availability. It's very difficult.
Oh, that's a huge challenge.
As well, like hospitalization, kids waiting in the ER for days and trying to find day program spots and, IOP spots. It's an ongoing concern. And then especially if you're, in solo practice, it's kind of it's a lot of weight on us to try to manage that in the conditions that we're working.
Yes.
Yes.
All right, so we're growing a little short on time. We have one more question in the chat, which I'd like to field. And then we'll ask, I guess, all of our panelists if they have any last words of advice for us. But first, for the question for fee-for-service practitioners, so I guess this is for you, Dr. Varon, how do you accept payment?
So more and more it's the credit card. I don't charge, you can these days charge an extra fee, but I figure for the rates that I'm charging, it just, I don't do that. So I do have my little a terminal here. So credit card and check. And more and more it's the credit cards that I get. And I do it at the end of the at the end of the, I handle my own thing. So I take it at the end of the session, or sometimes people have it on file. And some people like a check, and that's how I do it. I rarely have people give me cash, but it's possible. But that's what I do. And it's, it's always good to get it at the time, because out of sight, out of mind. So that's how I do it. And people, really at any one time, I have a very small amount of bills that haven't been paid. They usually get paid.
Yeah, I found the same thing in private practice when I was doing fee for service. It was almost never had any outstanding. I kind of had a joke my first year. I just kept like a Post-it note with the 3 people who owed me money in my drawer, because there's no other system for keeping track of it. I had so few outstanding bills. So that part was always easy. Okay. Well, thanks so much for your time. If there's any last words of advice from any of you, we would love to hear them.
I would just say that private practice is an awesome option, especially if you're looking for flexibility. That last minute doctor's appointment or needing to volunteer somewhere. For me, that's the biggest thing, where regardless if I'm doing another job on the side, I love to maintain the private practice because I have that flexibility, and then also the continuity of care with patients, across childhood, which has been amazing too, to watch kids grow and get to know their families in such a deep way.
Mm-hmm.
And I would piggyback on that exactly, it's almost, and actually private practice, I feel like it's the old model, hanging out the shingle, and it's very clear. Well, taking fee for service, your responsibility is to take care of the patient, they pay you, but in that, that transaction, it's more than that. I feel like I have students and walking the journey with the families and the patients, and you really become an integral part, not for everybody, of course. And I really enjoy that. And clinically, it's very rewarding, because you see how these conditions develop over time. You get to learn more and more about medications that, and you get to see, and then you really develop. And if you can't help somebody because they have a terrible mental illness, you can always help in some way, even walking with the parent. And I find that incredibly gratifying, and as exhausting as it can be mentally and physically, but it's a good tiredness, so to speak. And it's very rewarding. Now I'm 22 years old, 22 out. I've got some people in their mid-30s. It's really cool. I don't see everybody that late, but some that I do, it's really fun. It's nice. So it's really worth a lot.
It's a rewarding field, being able to start seeing someone as a child and follow them. I follow them into adulthood. And it's just rewarding to follow that trajectory, and they appreciate that. And as I've aged, I've had a few ask me, "Are you going to retire, Dr. Brett?" I go, "No, I have a few more years left." And they like that, because I understand myself that would be stressful. So that's nice. I mean something to them, and they mean something to me.
That's wonderful.
Yeah, that's really beautiful. Thank you so much. Nadi, do you have any final words or anything?
No, thank you for the panel, to the panelists and everyone who joined.
Thank
Yeah,
you.
that was wonderful.
Thank you.
Thanks, everyone.
Thank you.
Have a good night,
Bye.
everybody.
Bye.
Take care.
Bye now.
Bye.
It was good to meet you, Terry. Thank you for
Yeah.
joining us. I really
Yes,
appreciate it.
Wonderful. Thanks for inviting me. It's nice to be involved. Thank you.
Yeah, absolutely. Absolutely. Well, I'll be sure to invite you to the